Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and Associate Professor of Pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of April 21st, 2025. So let's get to our questions. First question. As a neonatologist, I am being asked a question about the appropriateness of the use of IM penicillin in midwifery birth centers for the prevention of group B strep disease in the neonate. Could an ID doctor speak on this? This is a very interesting question. I would say that the short answer is no, it isn't appropriate. But let's get into the background and the guidelines, and we can see what the data show to get a bit better of an explanation for this. We know that infants can get serious invasive infection from group B strep, and most of those infections are acquired from the mother who is colonized with the bacteria. The data suggests that the infants that are at the highest risk of developing group B strep disease are those that are born to mothers who have colonization or infection during this pregnancy, or if the mother has delivered a baby with a prior pregnancy that was infected with group B strep. We also know that maternal intrapartum prophylaxis with antibiotics decreases the risk of invasive group B strep disease in the newborn during the first week of life. Now, when we are choosing an antibiotic to treat a condition, it's guided by several principles. The first is that we want to choose an antibiotic that has activity against the organism that we're targeting. The second is that that antibiotic needs to achieve adequate levels to overcome the minimum inhibitory concentration, or MIC, of that organism at the site that you're targeting. The third is that we want to choose an agent with the narrowest spectrum possible in order to treat the organism without causing problems like resistance or collateral damage with the gut flora that can lead to things like C. diff. Fourth, we want to choose a length of therapy as short as possible, also to limit resistance and developing problems with C. diff. And there's other principles, such as making sure the drug is available, making sure it's cost effective, and making sure that it doesn't have untoward adverse effects. And of course, it's nice to have evidence that the drug you're using actually has good efficacy for the disease you're treating. So when it comes to maternal intrapartum prophylaxis for preventing group B strep disease in the newborn, IV aqueous penicillin is the drug of choice. And this is why it's recommended by AAP, CDC, and ACOG for this purpose. There are other first and second line alternatives for people who can't receive penicillin, so ampicillin and cefazolin are an option. And this is because the studies show that these medications do the things that we ask it to do: get to the place that it needs to go, have narrow spectrum, and have good activity. For someone who's allergic to those agents, you could try something like clindamycin, but there's problems with that because there is a high rate of resistance, and clindamycin doesn't penetrate the amniotic fluid very well. And of course, vancomycin is listed as an option in the guidelines as well. When it comes to intramuscular formulations of penicillin, there are a few options out there. The first is the aqueous penicillin G. That's the short-acting form that we give IV, but you can also give it intramuscularly. The other two are benzathine penicillin and a combination of benzathine and procaine penicillin. And those two are only to be given intramuscularly. I could see how in certain situations it might be attractive to give an intramuscular form of penicillin for prophylaxis. And when you look at aqueous penicillin G, you would think that IV and intramuscular should be pretty similar. Unfortunately, the pharmacokinetics are different for intramuscular versus intravenous aqueous penicillin G. And so for that and other reasons, the AAP Red Book specifically recommends against any oral or intramuscular formulation of antibiotics for prophylaxis for group B strep disease in the newborn. But let's talk a little bit more about intramuscular benzathine penicillin, because it's very different than intramuscular aqueous penicillin G. So intramuscular benzathine penicillin is a long-acting agent, and it can lead to systemic levels of penicillin for many weeks. There are a few studies looking at benzathine penicillin for use during pregnancy. For example, there were 2 randomized controlled trials done in the early 2000s that looked at giving benzathine penicillin to pregnant women and they looked at colonization rates at time of delivery. They looked at levels of penicillin in the blood of the mothers, and they looked at levels of penicillin in the blood of the babies at delivery. One used 2.4 million units, which is the standard dose, and the other looked at a double dose of 4.8 million units. Both studies involved about 100 patients, and they noted that at the time of delivery, 25% of the mothers still had colonization with group B strep. They also noted that there were no cases of group B strep disease in either arm of the study in the infants. Now, the numbers were very much too few to be able to tell if this was meaningful. Interestingly, though, they did find that maternal blood levels of penicillin 30 to 40 days after administration of the dose were above the minimum inhibitory concentration, or MIC, needed to kill group B strep in the blood. They also found that all but 3 of the infants tested had levels above the MIC needed to treat group B strep infection. The 3 that did not have high enough levels had been born to mothers who had received that intramuscular dose more than 100 days before delivery. So looking at that data, it would suggest that benzathine penicillin could be effective in preventing group B strep disease in the newborn, but we would need more studies to confirm that. But it's really important to remember that you would break the other principles of choosing an antibiotic. So a regimen of benzathine penicillin would expose the mother to many weeks of systemic levels of penicillin and the potential side effects that could go with it, the potential for disrupting the GI flora and giving you a higher risk of C. diff, and the potential for developing resistance. Contrast that to an IV dose of penicillin that's going to be out of the system within hours. The other major problem is that benzathine penicillin is often on shortage, and this is a big deal because it's really the only recommended drug for the treatment of syphilis during pregnancy. Any other medication has a higher risk of breakthrough disease, and remember, syphilis is a disease that has a 40% mortality rate in the fetus. So for these reasons, I would not recommend using benzathine penicillin for prophylaxis of group B strep disease in the newborn. Okay, on to the next question. Can you speak about the reemergence in the last 25 years of murine typhus and what occurs on a cellular level when bit by an infected flea? All right, another very interesting question. So there are 3 types of typhus. There's murine typhus, which is caused by the bacteria Rickettsia typhi, and this is transmitted by fleas. There is epidemic typhus caused by Rickettsia prowazekii, which is transmitted by body lice. And then there's scrub typhus, which is caused by the bacteria Orientia tsutsugamushi, and that's also transmitted by fleas. So murine typhus used to be much more common in the U.S. with high rates of disease back in the 1940s and 1950s. And it seems that with improved sanitation and improved pest control by using agents like DDT, that those rates really dropped quite a bit. So for example, at peak times, cases would be about 5,000 per year in the U.S. And then in 1954, after those changes were made, cases dropped down to less than 100 per year in the U.S. So because of that, murine typhus was removed from the list of nationally notifiable diseases in 1984, although some states still collect data on the number of cases. The animal reservoir is thought to be cats and rats and opossums, and transmitted by the fleas that bite them and then by other mammals and humans. It's still found worldwide, but most of the cases in the U.S. are seen in Southern California, Texas, and Hawaii. The bacteria infect the flea and enter the flea's gut endothelial cells, and then it gets into the feces, and when the flea bites the host, then it defecates, and those bacteria then are sitting on the skin of the host. Flea bites are itchy, and so the host then scratches that and often gets those bacteria into the system through the abraded skin. When this happens in humans, about 2 weeks later, the patient then gets the symptoms of typhus. So fever, headache, myalgias, nausea, vomiting, and then rash. Now, only about 50% of people with typhus get the rash, and the rash can be polymorphic, but tends to be maculopapular in nature, but it can develop into petechiae, and it can happen on multiple parts of the body without any specific distribution. The diagnosis is made clinically, but acute and convalescent sera and PCR are sometimes used in certain situations. Fortunately, treatment with doxycycline is usually successful. On the cellular level, the bacteria enter circulation and infect the endothelial cells, and this causes a systemic vasculitis similar to other rickettsial diseases like Rocky Mountain spotted fever. This vasculitis then leads to damage, and that causes activation of the coagulation and fibrinolytic pathways, and then you see additional damage, and this can really affect any organ system in the body. Over the last couple of decades, cases have been on the rise in Texas and California, with several hundred cases per year being reported in each of those states. The cause of that's unclear. They think it's likely multifactorial, but one of the theories is that the opossums, especially in Texas, are really able to move back and forth between wild areas and urban areas and bring those fleas into the system, which then can bite other mammals that interact with humans and can bite humans directly. I'm not aware of any cases that have been reported in Arizona, but we are quite close to California and Texas, so it may be something that we see in the future. For a more in-depth discussion on this topic, the CDC did a really nice hour-long presentation that you can actually watch and get continuing education credit. It's a clinician outreach and communication activity, call it COCA for short, COCA. The title is Murine Typhus, a Reemerging Threat in the United States. If you type COCA and murine typhus in your browser, it's really easy to find. All right, let's go to question number 3. Right now we are seeing the highest level of tuberculosis cases in more than a dozen years. With your knowledge, at what point would the U.S. recommend the TB vaccine for our population, and what was the reasoning behind the U.S. stopping the TB vaccine in 2005? This is another great question. Tuberculosis is an extremely common disease in the world, and worldwide it is estimated that a quarter of the world's population will get tuberculosis at some point in time during their life. Most people with tuberculosis get pulmonary infection, and disseminated and CNS disease are possible as well, and the highest risk for that occurs in infants and young children as well as immunocompromised people. The highest rates of tuberculosis are in countries with very few public resources. Fortunately, in the U.S., our rates are relatively low compared to the rest of the world. In the early 1900s, a physician and a veterinarian got together and produced a vaccine with activity against tuberculosis. And this is called the Bacille Calmette-Guerin vaccine, or the BCG as it's known now by its initials. What they did is they took Mycobacterium bovis, and this is a form of the bacteria that can cause tuberculosis disease, similar to Mycobacterium tuberculosis. But they took this strain and they passaged it over 200 times over the course of 13 years to get an attenuated strain that was no longer pathogenic. And they found that inoculation with this strain could give protection against TB disease. But BCG isn't your typical vaccine. It's given intradermally, and what happens is you give the vaccine and then a bleb forms. And then over time you get swelling and a scab, and sometimes you get painless adenopathy. After that, over the course of weeks, the scab falls off and there can be an ulcer that forms, and you can have quite a bit of purulence that forms sometimes. Over time, this area scars down and leaves a little circular scar on the shoulder. And about 80% of people who've gotten the BCG vaccine will have that scar on their shoulder. So if you're seeing a patient who's been born in an area where TB is endemic and they can't remember if they've ever been vaccinated with BCG, you can just have them pull up their sleeve and look on their shoulder to see if that scar is there. There are many different versions of the BCG vaccine substrains out there, and different countries have used them over the years, and that may explain why there is so much heterogeneity in the literature about efficacy of the vaccine. In recent years, the WHO published recommendations on vaccine preparation in an effort to more streamline and universalize the vaccine strains that are being used. When it comes to efficacy, the numbers aren't great for the BCG vaccine. That being said, in a fight against disease that affects a quarter of the world's population, any tool in the toolkit can be quite helpful. So studies suggest that there is a 0 to 80% efficacy rate with the BCG vaccine for preventing TB infection. Many experts think that the real-world efficacy is closer to 20 to 50%, and the highest benefit tends to be in infants and young children. And there's a higher rate of protection against severe disease, like miliary tuberculosis, disseminated disease, and CNS infection. At this time, the WHO recommends a single dose during infancy in countries that have a high rate of tuberculosis. Remember, the BCG is a live attenuated vaccine, so it can cause problems in immunocompromised patients. But despite this, and with proper screening, the BCG has really a fantastic safety track record. And over the years, there have been very few cases of deaths published in the literature from the BCG vaccine. This is really quite impressive when you consider that over 4 billion doses of the vaccine have been given over the last many decades since its development. The BCG vaccine can cross-react with the tuberculosis skin test, or TST, also known as the PPD. The highest reactivity tends to happen over the first year or two after vaccination and usually wanes over time. Because of the BCG's low efficacy rates, in the U.S., it is recommended that one interpret the tuberculosis skin test independently of BCG vaccination. And that's because there's a high rate of people who get infected despite having BCG vaccination. Now, one potential solution to the cross-reactivity problem is that interferon gamma release assays, or IGRAs, such as the quantiferon gold or the T-spot, don't have cross-reactivity with the BCG vaccine. So if you're trying to sort out tuberculosis infection using tests and someone has BCG vaccination, using an IGRA is one option, and IGRAs can now be used at any age. The U.S. has never had a universal BCG vaccination program, and this is probably for multiple reasons. Number one, our rates of tuberculosis are low. Number two, the efficacy of the BCG is low, and there are the potential for adverse effects in immunocompromised patients. And also this potential to cross-react with the TSD, which can make it difficult to sort out outbreaks and exposures and infection. There are still some situations where BCG vaccination may be considered here in the U.S. For example, if there is a young infant who has ongoing close contact with a caregiver with tuberculosis, and that caregiver can't take medication or can't limit interaction or can't wear a mask, then BCG vaccination can be considered in that infant. Also, if a person of any age has continued high-risk exposure to someone with multi-drug resistant tuberculosis, they can consider receiving the BCG vaccination. Will we ever have recommendations for universal BCG vaccination here in the U.S.? I doubt it. I don't think we'll ever get to rates that high. But again, we'll have to see what happens with our future. But with proper investigation and public health, it really shouldn't get to that rate. All right, final question. Due to federal funding cuts, dozens of free measles vaccine clinics closed in Texas. What does this mean for high outbreak locations? Due to these outbreaks, do you feel more parents will advocate for child vaccines? Another great question. We continue to see budget cuts in all areas of health-related programs, and unfortunately many of these came without prior warning, so it's making it harder for people to prepare for and deal with them as they come. We know that when funding to diagnose, treat, and prevent disease is cut, the rates of these diseases and their sequelae increase. And I can only imagine that the measles epidemic is going to get worse because of it. Now, one possible side effect of the ongoing epidemic is that many people are going to see that these diseases are still present and are in fact causing real and permanent harm to people's lives. So I suspect more people are going to see that and recognize how useful vaccines are in preventing those diseases. So yes, I think a lot of people will get off the fence and lean towards vaccination, but I think there's a lot of people that are dug in so deep against vaccines that no matter what happens, they will continue to advocate against vaccination for themselves and others. So it's up to us to continue to advocate for those that we care about, our families, our patients, ourselves. We need to continue to get the word out about how effective these vaccines are and how important these programs are to help the people in need to get the care that they need to prevent the spread of these diseases. Well, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services, the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.